All right, well, good morning, everyone, and welcome to this webinar. This is a brief overview of child-parent psychotherapy. My name is Rhonda Reardon Nelson, and I am a community health consultant at the Iowa Department of Public Health. I provide staff support to the Iowa Association for Infant and Early Childhood Mental Health, and I'm really pleased to welcome Gladys Alvarez. Gladys is a good friend and a colleague whom I've known for several years. She certainly has a passion for infant and early childhood mental health, as well as for trauma-informed care, and she is a member of the Iowa Association for Infant and Early Childhood Mental Health. As a therapist at Orchard Place Child Guidance Center, Gladys has been trained in child-parent psychotherapy and has graciously agreed to provide us an overview of this evidence-based intervention. So I'm really excited. I know I've had other people email me too, and they aren't able to be here today, but they would like to view the archive on our website. So just a couple of housekeeping items. I have muted everyone. We have a pretty small group, but you are placed in listen-only mode. If you have questions during the presentation, if you could type them into the chat box, and we will definitely take a look at those at the end. And again, if our group is small enough, we can unmute everyone at the end and just give opportunity for questions live. So I think with that, I'm going to go ahead and turn it over to you, Gladys.
Thanks, Rhonda, a lot.
Thank you.
I'm excited to give the overview, and hopefully it answers anyone's questions about it. Most of the slides that I'm using this morning are taken from a presentation by Joy Osofsky and Mindy Cronenberg. Those were the two who first trained me in CPP many, many years ago, in about 2009. All of the slides are based on Alicia Lieberman and Patricia Van Horn's work. So when it's an NCTSN slide, that should be noted. Okay. Our historical roots for child-parent psychotherapy are based with Freiberg's infant-parent psychotherapy and goes to the nursery work. When Lieberman reframed it as a toddler-parent psychotherapy, and yet there are lots of people working, Poss, Pincetti, Van Horn, and others, working with infants and toddlers in preschools, and pretty soon they became aware of the question, are we confusing people by calling it so many different things? And we know that we've run into that same question with our work on ACEs and trauma-informed care. So Lieberman and Toth agreed that child-parent psychotherapy would be the term used for therapeutic interventions from infants, children from birth to 5. In 2002, Lieberman and Patricia Van Horn actually created and manualized child-parent psychotherapy. It is a relationship-based dyadic intervention. It is manualized, but having said that, it's not prescriptive. In that it's a very flexible model, even though it is manualized. The model has been done in homes and office-based. Lots of times, home-based mental health therapists will go and use this in the home. And then, of course, you get a different feel when it's in the home versus when it's in the office. It has been used in a couple different languages. Spanish is one of those. Really ideal for infants and young children who've experienced trauma, initially focusing on domestic violence, as you'll see in the next slide or so with the title of the manual, but it really is applicable to all types of traumatic experiences between children and their parents, or traumatic experience that a child witnesses that maybe the parent isn't the perpetrator or involved in, but is still having issues with. So it is a multi-theory approach to infant mental health, in that it comes from developmental psychotherapy, psychoanalytic, trauma theory, social learning, lots of attachment theory throughout the child protective or child CPP model. It is a behavioral model, and it does use some cognitive behavioral interventions. One of the key components in the model is the awareness of the cultural component for both the family and the therapist, and so looking at that, and it can be used multiculturally. as I said before, attachment runs throughout the CPP framework because we know that attachment is the main organizer of a child's perception to life and their safety and whether or not they're in danger. We address that threat of safety through the relationship and in attachment. So this CPP model really promotes the growth in the caregiver-child relationship to help develop more appropriate mental health, but emotional and social health as well. Hopefully, those interventions last a long time after we're done with the family and CPP. It is a joint narrative, which is one of the things that's very different than like trauma-focused cognitive behavior therapy, where the child would do the narrative and we would be working with the parent, but we would bring them in and review the narrative with the parent. In child-parent psychotherapy, both the child and the parent together work on a narrative. Another thing, unlike TFCBT, trauma-focused cognitive behavior therapy, where the narrative is shared at the end and it is like a product. In CPP, the narrative is an ongoing thing, and so you get little snippets of narrative throughout the therapeutic intervention. You get not just the child's version, but also the parent's interpretation of those, and those narratives aren't a narrative necessarily in a story, but might come through play, might come through out in behavioral messages as well, because we know that children express themselves through their play and their behavior. This is the manual for child-parent psychotherapy. As you can see by the title, Don't Hit My Mommy. It was initially around domestic violence and physical abuse issues. This is the second edition. This edition has additional resources in the back of the book that help promote the fidelity of child-parent psychotherapy. Goes over the 3 phases of child-parent psychotherapy. The first phase being the assessment engagement phase, a foundational kind of phase. The second one, the core intervention phase, where you would be looking at the ports of entry and things like that. And the last phase would be the recapitulation and termination phase. Anyone doing therapy knows that's kind of the standard 3 phases of any treatment work. In addition to those phases and fidelity checklists for those, it also has 6 strands of fidelity that it looks at, which are really important to child-parent psychotherapy. The first one is reflective practice. Child-parent psychotherapy is really big on reflective supervision and just reflectiveness in general, and that's a very key component. So the supervisor holding the therapist holding the therapist's emotions in their hand, while the therapist is holding the parent and the child in theirs and reflecting on that transference and countertransference. The second strand would be the emotional process. The third, the dyadic relational fidelity. Where is that at? The fourth, the trauma framework. The fifth, procedural fidelity. Are you actually following the framework of CPP? And the sixth being the content fidelity. So with those additional fidelity checklists, it really, really is an evidence-based practice. The central goal of child-parent psychotherapy is really to support and strengthen that parent-child relationship, helping parents understand how to help best help their children feel safe and secure. We know that when parents learn that the behavior has meaning, that understanding can help them help their children name and cope with strong feelings. So that's really what the entire intervention of CPP is helping that attunement between parent and child and helping the parent rename, understand, support the child in those strong feelings that they have to any trauma triggers. The goals in child-parent psychotherapy, obviously to return the child to a normal development with adaptive coping, increasing the capacity strategy to respond to realistically to any threats instead of the fight-flight freeze that they may have developed. Maintaining that affective arousal level. We know that we get stressed, but being able to come back down and be soothed. Really reestablishing trust in our bodily sensations, and so not attributing body messages as danger always, and recognizing how our body feels when we're under stress and what to do about that. Doing that reciprocity with that intimate relationship, helping both of them have joy together and have mutually positive interactions, the parent and the child. Normalizing the traumatic response. Differentiating between reliving and remembering. It's important that families remember the trauma. We're trying to help them not relive the trauma as we're working through child-parent psychotherapy. So actually, we're putting that traumatic experience into perspective, which any good trauma therapy, trauma-informed therapy, should be doing. Help normalize that traumatic experience, those body sensations, and help put it into perspective, assigning appropriate fault and understanding. There are 6 different kinds of interventions that we use during parent-child psychotherapy. We try to promote positive developmental progress by using play, physical contact, language. Lots of times when we're working with these families, many times the parents have been traumatized themselves and they don't really know how to play, or the physical contact that has been made between parent and child has not been positive, it's been negative. And we know that being beings of attachment and relationship, we need to be able to experience that positive physical contact. We do that by offering unstructured reflective developmental guidance. Unstructured because it happens in the moment, and we use different cards as we're doing that reflective guidance to either the child or the parent. Oftentimes we are modeling protective behavior, particularly if there's a risky thing happening and the parent isn't cueing into it. So then we're modeling and talking while we're doing that, how to keep the child safe or what that behavior might lead to. As we're modeling, we are interpreting feelings and actions. Oftentimes we do that by using speaking for baby or using the all famous I wonder statement. Providing emotional support and empathetic communication to not just the child, but also the parent. Oftentimes, the parent doesn't have a very big or appropriate support system. Often they feel like nobody's listening to them, particularly if they're involved in the system. And so one of the things that CPP offers is that empathetic listening and communication and advocating for both the child and the parent when it's appropriate throughout the system engagement. Number 6 there is really a key component for child-parent psychotherapy, because often parents are coming in, families are coming in crisis, and so we're doing a lot of crisis intervention. It might be because the child's getting kicked out of daycare. It might be because they've been removed into foster care. So unlike many other trauma-informed interventions, child-parent psychotherapy has a lot of case management and concrete assistance wrapped up into it. Ideally, if you have an agency that has some case management or VHIS services or integrated health programming, you have colleagues who can help with that case management. If you don't, then a lot of CPP deals with Maslow's hierarchy, I would say. We know that until people get their physiological needs met, they're not able to have emotional and psychological safety, let alone perhaps physical safety. And so part of child-parent psychotherapy is working with and collaborating with the larger system that that family is involved with to get those basic needs met, so that the intervention in CPP can really focus in on those psychological needs, building that relationship, friends, that support system, helping the parent feel competent, having a sense of achievement. But that can't happen very well until that very bottom part of Maslow's hierarchy is done. And so CPP, unlike other trauma-informed interventions, really focuses in on how can we get those basic needs met for this family so that they don't have to worry about that and they can spend their energy in other areas. As you can see in front of you, there are 3 circles. So there are really 3 parts of parent-child psychotherapy: the child, the parent, and then the relationship between the 2 of them. It is the relationship that is the client in CPP. The parent isn't necessarily the client, the child isn't necessarily the client, but it is the relationship and how the parent and child experience each other, how the child is internalizing what the parent's experience is, and how the parent is internalizing what their experience with the child is. Those emotional parts of therapy are key ingredients, and that's really part of our reflection and our intervention, is helping each partner understand how they might be impacting or affecting the other. Clearly, the parent is the partner that needs to establish safety. Infants and children can't do that, but infants and children often cue to their parents, and sometimes they take on almost a caregiving role, and so helping rework that hierarchy and reminding both entities how the other one is experiencing or their thoughts behind that. Need to be able to have empathy on both sides at all times, which is a little exhausting at times, because at one point you might need to focus in more on a parent's behavior or the child's behavior. Sometimes it's the relationship that you focus in on. It's important not to take sides, though. And often if we're, as a therapist, feeling like we're taking sides, that might be some countertransference going on, and it's an important thing to utilize supervision during that. Many times we are not working with both parents, but one or the other parent. It's also important not to take sides, one parent against the other, but to help recognize the feelings there and look at ghosts, look at angels in the nursery. In doing that, clearly we are offering that emotional support and that empathetic communication. We know that relationships, one of the most important things to establish first and foremost is trust. That's the same in CPP. So the therapist is really trying to first build that foundation of trust and emotional availability. Again, we might be the first person that parent feels who's actually listening to their story, who actually is thinking that there's hope that they can actually achieve their goals and be a better parent, do different coping strategies. So we want to encourage that and build and encourage them to express themselves appropriately, support their reality testing. That would go for the child, though, too, because we want the child to be able to communicate their reality so that the parent is better understanding how they're perceiving whatever the trauma was and helping correct any distortions. We know that kids might find experiences stressful, and we want to teach them that it can be less stressful if they're able to let adults help them. Oftentimes kids blame themselves and they think that adults can't help or haven't helped and can't protect them, and so they begin to feel like they're in this on their own, and we want to rework that and reframe it so that they know that life can be pleasant, there is hope, so that we can have a shared mutually pleasant experience between both the parent and the child, keeping them focused in the present and looking towards the future goals rather than reliving past events all the time. One of the first things we do in child-parent psychotherapy is an assessment, that first phase. We do a comprehensive evaluation of psychosocial history. In that, with child-parent psychotherapy, we actually do a mental status exam of the parent more than we would in other cases. And one of the tools we use is working model of the child interview. We might also use the life stressor checklist for the parent to fill out on their own experience. So we have a trauma screening for them and what's been happening to them so that we can understand some of those ghosts in the nursery that might pop up in therapy. We do a crawl observation, which is done in the playroom, usually here. It can be done in a home setting, as I said before. Having the parent have some free play time, some structured pickup time, some teaching tasks, a separation. If the child is older with little kids, we use a still face to see how the infant, or if we're doing the separation, child reacts to being separated from their parent. We also look at how the parent prepares or doesn't prepare the child for that separation. When the parent comes back into the room, then in the CROW, we look at that reunification. How is the child, or is the child wanting the parent back? How stressed were they upon separation and upon a reunification? All of those give us some clue about that relationship building. Again, CPP is all about that relationship, finding strengths and weaknesses and helping that family, that relationship be better between the two. Usually we have, it's evidence-based 0 to 5, and usually that's the set of little kids that we use it with. However, you can use it up to 7 or 8, and I have actually used CPP with 8, 9, and 10-year-olds who are emotionally really acting like a toddler, 3, 4, 5, doing the same types of interventions and using the same ports of entry that we're going to talk about. When you're observing the parent and the child, a lot of child-parent psychotherapy, the therapist isn't in the mix of things. We're kind of on the periphery unless the family is needing us to be involved in their play. But as we're watching, both in the CROL and ongoing CPP, we're actually looking at what kind of feelings are the parent and the child transmitting to each other. Are they enjoying each other, or are they getting real frustrated with each other? How are they actually transmitting that? Who, if there's a stress in the relationship, who in that dyad is responsible for the recovery? Is it the child going over and soothing the parent, or is it the parent being able to be there and be the comfort seeker for the child? How do things move forward? One of the mantras of child-parent psychotherapy is, don't be a better parent than the parent. Don't be a better mom than the mom or the dad during the session. Having said that, there are some times when, particularly around safety issues, when you have to jump in and you have to be, quote, a better parent. When we have to do that, though, we have to fix that with the parent. We have to explain, you know, oh, I'm sorry, it scared me, that's why I jumped up and did that. I know you would have taken care of it, or maybe you didn't see what was going on, but helping them key into what had just happened and that made you perform their duties as a parent. So basically, when we look at a family, we're actually trying to help them balance that continuity of daily living. On the one hand, we have their trauma history, their family conflicts, perhaps health concerns, maybe some environmental stressors like poverty, those lower level Maslow kinds of things. On the other side, we are trying to foster predictable routines, helping them with self-care, having pleasant activities, building that relationship so that the demands of daily living become balanced and not overwhelmed. There are several different ports of entry. These are some of them. Another mantra for child-parent psychotherapy is, it's okay, if you miss a port, it'll come around again. So not to beat yourself up on like, oh, I should have done something there. Because again, child-parent psychotherapy is treatment in the moment. It's not a prescriptive type of modality. So themes tend to repeat themselves. We want to begin with the most simplistic port, and we want to look at timing our developmental guidance for the most effective intervention. Safety is critical, so that's the very first thing that we want to have the family feel is safe. So as we're doing and selecting our ports, we're thinking of the relationship within the family, where we're at in the treatment phase, how well we've engaged with the family, if we've got a good relationship going, and so we might be able to challenge a belief more readily as we're well into treatment, where we might just, note to self at the beginning of treatment about different things. We also want to look at the parents and the child's affect and how using this particular port will enhance that or might inhibit those. When we look at the child's or the parent's behavior, we know that children test limits. Of course, we're going to intervene if there's safety, but we're wanting to do that developmental guidance. And say, we might say things like, oh, he's wanting to see if you really mean he has to pick up right now, or he wants to know if you think climbing on the chair is safe or not. When we're looking at parent behavior, we do a lot of reflecting. Oh, mommy wants to make sure that you're clean. That's why she's struggling so hard to change her diaper. Just reflecting in the moment whatever behavior activity is going on and having some meaning associated with those behaviors. When we're looking at the parent-child interaction, we might be looking for symbolic play and being able to interpret that to the parents, or reenactments of trauma. See whether either party is wanting the other to, what their expectations in that reenactment are. Sometimes the attributions can be positive or negative, and we want to really highlight those and reframe the negative ones so that, particularly if it's a safety issue, looking at this is why the child is mad. Say a child is hitting a parent, and the parent's like, I've done nothing wrong, I don't know why they're hitting us. It might be that happens every time the other parent is mentioned, and the child in question is really angry that the other parent is missing. And so to reflect that, she thinks you're mean, she thinks you're the one who made daddy leave, might be helpful to the parent and the dyad, the relationships, and look at that and reframe why that happened. Oftentimes when you're working in any kind of therapy, you might have conflicts between the parents, particularly if the parents are not together. So looking at those conflicts, either interactions or that you've seen the parents and the child has seen the parents have together, and helping the child understand those conflicts, helping the parent understand how the child perceives those conflicts, and attributing meanings to those. Another port of conflicts is how the various siblings get along with each other. Most of the time, you're working with one child and one parent in child-parent psychotherapy. Having said that, there may be a point where you have a sibling session so that you can better understand how the parent is able to manage or not able to manage relationships of several children at one time. And as parents, we know that it's hard sometimes on a given day to give everybody the attention that they're needing. Sometimes the therapist becomes the port of entry themselves, or how the parent is feeling towards the therapist. Parent might actually feel threatened by the parent or by the therapist, either because they perceive us as more powerful than them, or we're very dangerous in that we have the power to report. They might perceive that we have the power to either be helpful in the court or not helpful to them. The other thing is that our own culture as a therapist is part of this interaction, in us understanding how I, as a white female, might be seen differently by an African American male in session, and how I might need to actually look at that and reflect that, and have some cultural awareness in that. Again, the three different stages are that engagement phase, that treatment phase, and then termination phase. When we're looking at where to intervene, there are several different places, several different domains. Play is generally in all-encompassing. You want to have materials that are age appropriate, that give them sensory stimulation, things for soothing, things that are reminiscent of the trauma. So if, for example, there was part of the trauma was a fire, then you might have available in the playroom little toy fire trucks and helping professions, dollhouses, and things, so that the child can actually act out their traumatic experiences. Trying to have both nurturing toys as well as toys that might be more aligned to aggression. Really wanting to look at how the child and parent are verbally exchanging things with each other. How does the parent reference the child? What kind of names do they do? Does the parent use derogatory names, criticize the child, tell them they can't do anything right, threaten them with corporal punishment during session? Looking at all of those. We are always looking for any ghosts from the parents' past, but also any angels. We know that along the line, parents, we all have ghosts, things that didn't go well in our past that we bring into our present day, and helping parents understand, oh, I think this might be related to when you, as a kid, saw your dad die, or things like that. But we also have angels, people who kept us going. And so doing a lot of wondering, I wonder who helped you carry on. I wonder who was your source of support, kinds of things. We need to remember that ending sessions is a loss, and making sure that the child is able and the parent is able to go through losses well and know that there's still a future. So saying goodbye, ending sessions, ending treatment in a very predictable, consistent manner is important. Ending relationships is important. And that's one of the things that we teach in child-parent psychotherapy as we're getting close to the end of treatment, is how to end relationships appropriately. Because many times parents we work with and children have not had that. We're helping parents understand that their child's behavior has meaning. It's not just to annoy them. That those behaviors might be motivated by anxieties, especially if they feared something and then it came true. They feared they were going to be taken away, and then they were. They feared somebody was going to die, might have been even so mad that they actually said or thought that, and then that person died. So really having some emotional expression and knowing that that might be a displacement of feelings from earlier losses and trauma and not what's going on right now. The same is true for the parents, however. How they're interacting with their child may not have anything to do with that child. It might be that that child reminds them of their abusive partner or of something that happened to them early on. And so reflecting that back and making sure that we're attributing meaning and reassigning appropriate responsibility for things. It's important to know that no matter what port of entry we choose, we don't intervene without thinking a bit, how is this going to disrupt the child's play? Sometimes it's important to just let that play out. Other times, we need to interrupt. If we're going to reflect or wonder, do a meaningful translation, how intrusive is that going to be seen by the parent, by the child? Is the parent even ready to hear that translation? And as they get further into therapy, then parents are more able to hear, oh yeah. And sometimes they get angry with you in the moment, and then several weeks later come back and say, you know, when you said that he reminds me of my ex, I was really mad at you when you said that, but now that I think about it, you're right. And I'm going to make sure that I don't think to myself, you're just like your dad, when that's not a positive attribute. So essentially, in CPP, we're holding the relationship. And we have 3 cards to choose from when we're holding that relationship and when we're doing an intervention. Are we going to do intervene as a parent card, in which we're going to maybe speak and reflect the parent's intent to the child? Are we going to intervene using the child card, and so we're going to speak for the baby or for the child or reflect how the child might be feeling? Or are we really holding the relationship card and working on that interaction between the 2 individuals? Likewise, with a supervisor in supervision, the supervisor has the therapist, the parent, the child, and so they too are holding all of these cards. When we proceed, we want to try the simplest, most direct intervention first, encouraging the parent to intervene on behalf of the child whenever possible. So we might suggest, instead of doing for the parent, we might speak for the parent and say, oh, mommy, I wish you would read this book to me, if the child's been trying to hand her mom a book and the parent's been engaged in something else and not attuning to the child. We want to be careful what of the parent's past we actually talk about in front of the child, particularly taking into consideration the parent's culture. Or if the parent really isn't stuck in the past, then there may not be a reason to actually bring up anything in the past. So again, being sensitive to, will this be helpful or harmful in what we're doing in the joint session? From time to time, we may need to have separate sessions with the child and the parent, particularly if it's around the parent's past. We might need a parent-only session to get more clarity about traumatic experiences the parent had, to wonder more specifically with the parent on how those experiences are impacting their ability to parent, so that we don't cut the parent down in front of the child, and they're able to use that knowledge to go on. Need not to be afraid of conflict. Conflict happens in relationships. So one of the things that we do in child-parent psychotherapy is we go with conflict. We help parents and children know that conflict happens in real life. It's not bad. It's an opportunity to learn, and we go for it, and we help fix the conflict or emotionally deal with the conflict, because conflict is all about regulation, really. In child-parent psychotherapy, there is no one right way to do it. There's no one correct intervention. As I said, it's a very ongoing, living kind of therapy. It allows you to use your own unique style based on all of those developmental frameworks and other theories. There are a couple things, though, that are not CPP, that are counterintuitive to CPP. Having a bug in the ear like they do in PCIT, that isn't how child parent psychotherapy works. Either a bug in the ear for the parent or the therapist. Again, because there's no set interventions that you have to do. It's not prescriptive. While it's manualized, it's not a prescriptive. You don't have to do this first and this second and this third. We don't do the flooding of interventions or using adverse stimuli or real desensitization. Now, as we bring up the trauma, we are gently and briefly desensitizing in that we're seeing how both the parent and the child are reacting to that mention of or that play about the fire or the mention of grandma who died or things like that. But we're not actively doing desensitization. It is not a curriculum-driven dyadic instruction, and it's not any intervention that's not based on developmental principles that don't understand or acknowledge each child has their own individual experiences and characteristics, as does each parent. Those would be things that would not be compatible with child-parent psychotherapy. Again, we want to promote growth in the parent-child relationship and support healthy development. We want to emphasize the legitimacy of affective experiences, promoting both a sense of competency in both the child and the parent. We want to provide a safe place to talk about, and talk is relative because talk might be done in play with kids or express rather than doing that expression in negative feelings or experiences or behaviors. We encourage play, encourage safe physical contact, particularly nurturing contact, snuggling, attending to boo-boos and owies, even if they don't exist really in, that kiss it and make it feel better kind of thing. Encourage language development and talking through and just one of the fun things I do when I'm doing child-parent psychotherapy is I tell a parent, you can just pretend you're a reporter and just talk about what they're doing. It might sound senseless to you, but that helps build their language. Using books, encouraging play, finger play, nursery rhyme kinds of things. Looking at overwhelming feelings, correcting misperceptions. Obviously using developmental guidance in an age-appropriate context. Reframing, helping parents set appropriate limits are really important. Looking at those developmental themes that can be really surprising for the parent, or the parent might not be comfortable, particularly if one of the themes is kind of normal aggressive behavior or normal autonomy behaviors wanting to do for themselves. The parent might feel rejected. But helping the parent understand, no, really, at this age level, it's really normal for the parent or for the child to want to do this on their own. That doesn't mean they don't want to anymore. Helping them understand about rapprochement, how the child has to go out and explore the world and seeks to come back to the parent, and establishing that safe, secure base so that the child does come back and know that there's a safety net there for them. Modeling appropriate protective behaviors, being a better parent in the moment if we need to, if there's a safety issue, and then fixing that relationship with the parent, repairing that. Helping the parent become aware of their unconscious things that they're doing. Perhaps they're not aware that they're always directing the child in how to do things rather than letting them explore and letting them kind of problem solve on their own. And so looking at those kinds of things. We need to look at when we have emotionally laden experiences, but we also need to know our own limits and seek supervision in that. So this is where I was talking about we might need to divide sessions, have half of it be more parent-centered, the other half be more child-centered, or actually have separate sessions and meetings to work on particular individual issues. oftentimes the parents that we work with have a whole host of mental health issues, ghosts in their nurseries that we can't address appropriately in dyadic relationships and the CPP model, and we would want to be making referrals for those. Remember that it's not finding the perfect answer, it's doing something. And when we have to jump in or we weren't perfect in our intervention, then going back and repairing that relationship, repairing and owning our mistakes, because then we're modeling for the parent that you don't have to be perfect either. You can tell your child, I screwed up, okay, that didn't mean to do that, or that didn't go as I had planned, and just really modeling that type of thing. So this is where we use supervision a lot. We oftentimes, child-parent psychotherapy, there are counter-transference things that come up, either the parent transferring things on to you as therapist, or you actually being triggered by this. You might be linking more with the parent or with the child and the parent, and you might really dislike the parent. That's not uncommon. And so discussing that in reflective supervision is important. Oftentimes, if we go from really not liking that parent to liking the parent, that is a huge indicator of change and positive growth in the therapy. That is what I have to say about child-parent psychotherapy. I don't know if there are questions or if anybody has some reflections or thoughts that they wanted me to address. Are you all there?
Yep. I don't have any questions.
Hey Gladys, this is Judy. I got on a little bit late.
Hey, Judy.
Hi. Did you, in the beginnings, did you talk a little bit about when it's, I guess, appropriate to use in case situations, or the appropriateness of a referral during child welfare case situations?
I didn't. Are you talking about don't refer them for a relationship-based assessment if you're at the termination phase?
Yeah, kind of like that.
Yeah.
And helping, the participants on, at least on this call, helping them provide some clarity to maybe attorneys and judges that they may come across, or other service providers, case managers, so on and so forth.
Right. So when we're doing that initial assessment for child-parent psychotherapy and doing that CROL, the CROL basically is that relationship-based assessment. And what we're looking for are strengths and weaknesses. Oftentimes, I can see lots of weaknesses, but many strengths. And child-parent psychotherapy tends to be, if it's done well, tends to be a longer process therapy than, it's not a brief treatment modality is what I'm saying. And so it's really not fair for, if the case, juvenile court case is up to, we're at the point of TPR, and now we're going to get this assessment done, because I might, I won't have time to do any work with the parent. Now that doesn't mean that even if it's at the beginning of the case, that sometimes we don't get to TPR, but then having the opportunity to help that parent give permission to the child or the adoptive parent and doing those goodbyes in a structured setting and helping that child and parent fix that relationship so that the child can carry it on to other relationships is important, but not at the very end of the court case. It has to really be at the beginning of the court case for there to be hope for the parent, you know, that if I really do the work with my child, I can be involved in their life. Does that answer your question, Judy?
Yes, ma'am.
Okay.
I realized earlier I was talking and I had unmuted everyone except me. So apparently I wasn't, no one was
Oh, I
able to
didn't
hear
hear you
me.
at all, Rhonda.
Yeah, I unmuted everyone but myself. So we did have a question. Is CPP readily available across the state?
I would have to say no, it's not readily available. There is a cohort over in the Council Bluffs area, Lisa, who went through the CPP training with Becca and I in 2009, and she's available. I have her contact information on my computer that I can send you. Here in the Polk County area, there are therapists trained at CFI, Children and Families of Iowa, and also at Compassionate Clinical. Is that name? Eileen Swoboda's that cohort. And then here at Child Parent or at Child Guidance Center, we have 10 therapists here at Child Guidance Center who are trained in CPP. So there are all of the early childhood mental health people are, and then there are some other main center therapists who are trained as well. I'm not sure in Cedar Rapids, in CFI, I don't know. It's one of the things that we're trying to get more people trained in CPP.
Yeah, I'm definitely hearing more and more about CPP, and I have heard of several people who are becoming trained in this. I know I sent out the email this morning, and Yolanda Dixon responded that she is trained in it and that she really appreciated that we're providing this. So, yeah.
There were 17 of us that just got rostered with the national in California to be child parent psychotherapy.
Okay.
There.
So your training is complete now, is that correct?
Yes, my training is complete, and all of the 10 therapists here at Child Guidance Center, their training is complete. We're working on building a network of people who are trained in child parent psychotherapy and meeting at least quarterly, so that we can help each other stay current with the Fidelity Skill Model and do some learning kinds of things.
Yeah, we're gonna have the locked cabinets. There's gonna be like a big cabinet.
Who is that?
Oh, I think that was just someone that was not muted. But we do have a question. How does Child Guidance Center handle reflective and clinical supervision for child parent psychotherapy?
How do we handle it?
Yeah, how do you, go ahead.
About 2 years ago, we had our supervisors go through training on reflective supervision. And so they're trained, and then of course going through the child parent psychotherapy, there were 4 supervisors who went through this cohort of child parent psychotherapy, and part of that, the supervisors were also on a supervisory call, so we got trained again in how to use reflective supervision in with CPP cases. So we offer our therapists regular supervision, and those who are doing CPP, part of that is reflective supervision. We also have a once-a-month child parent psychotherapy case consultation group, and we do some group reflective supervision in that manner.
Okay, so Kelly had a couple of questions. She was wondering, first of all, how much time is devoted each month for reflective consultation? And then second, how did you get administrative support for that?
Those are really good questions. How much time would depend on which supervisor you're talking about and at what level their person is. If they're not independently licensed, then those people get 1 hour supervision weekly until they are independently licensed, and then generally it's 1 hour every other week type of thing. Administrative support, Orchard Place is just really good in knowing supervision is a must-do thing, and so we've been doing trauma-informed practices since way back in 2007 or so when Dave Stout was our vice president, and he just really knew that in order to have any fidelity to models, you have to be able to have that capacity to have supervision. So we were blessed with that. It really does, and there's studies that show if you are practicing trauma-informed care, it will reduce employee turnover and employee satisfaction. And part of trauma-informed care is having that ability to do some self-care. And part of self-care is having that space, safe place to do some reflection about how your cases, your work is impacting you, or how your home life is impacting your cases, kind of thing.
Thank you. Are there any other questions for Gladys?
I think that if people can't do individual reflective supervision, it is really important to at least try to have a peer consultation reflective supervision space for people to do that.
Gladys, I'm curious, from the macro level in terms of financing child parent psychotherapy, is this something that is typically paid for by third-party insurers, whether it's private insurance or Medicaid, or can you talk a little bit about that?
Evaluation and any parent-only sessions or parent-only sessions. And so the part of it is if their insurance pays for parent-only. Another aspect is the client is the child, and so you get into diagnosing. And if the diagnosis is one that's accepted by insurance companies. If it is, then yes, insurance companies generally pay for it. And generally there is a diagnosis that will fit for those. But it doesn't pay for any for time, just like it doesn't pay for any for time with any other, for the scoring of the CBCL or the life stressors checklist or anything like that.
Okay, so it typically pays for the intervention itself, but not for the information collecting. Is that what you were saying?
Correct.
Okay.
But
Yeah,
that would be like any other therapy case.
Sure. I work on a national committee that's looking at policy, and that's one of the things that we've talked about is just a barrier with third-party insurers is that there has to be a diagnosis in order for insurance to pay. And we understand why that is, but it also presents a lot of challenges and a lot of barriers because diagnosing children so young can be kind of dangerous in terms of labeling them. So I don't know what can be done about that, but that's something that we're looking at from a policy issue.
Right, and the DC 0 to 5 does a nice job of crosswalking things over to ICD-10 for billing purposes. If though the only thing you have is a relationship-based diagnosis, if that's the only thing you can give, that's not going to get paid for by any insurance company because it'll crosswalk into a V code.
That's helpful to know. Well, this has really been wonderful information. Thank you so much for pulling this all together and for being willing to present this. It's just like I said, I've heard so much about it, and so it was wonderful to just kind of get that glimpse of it. For those who are joining, if you are thinking you might be interested in applying for endorsement in infant mental health at some point, if you are interested in a certificate of participation, just send me an email. Certainly there are many of the competencies that would be applicable to this particular webinar today, and it was an hour in length, and so you were able to select one competency to apply that to your endorsement. So if you would like a certificate, please just send me an email. And Gladys, thank you so much again, not only for this, but just for all of your work to promote children's mental health and being involved in the association in Iowa.
Thanks for asking me to talk, Brenda.
Absolutely. Thank you all so much. Have a wonderful day.
Bye.
Bye-bye.